It's complicated because there are so many factors that weigh into the decision making. First of all, there's a ton of treatment options to begin with. And then you need to factor in patient-specific factors, your patient's age, their underlying health, their goals of treatment. You also need to factor in what the patients have had previously and how well those treatments have worked. You know, if a patient receives something in the front line and it worked beautifully and they tolerated it beautifully, then you could offer that again, just as an example. That doesn't happen terribly often where we give the same thing over and over and over because there are so many options. But if you take, say, the most common scenario, let's say you have a patient who received bendamustine rituximab and maintenance rituximab and they got a nice remission, but it's 3, 4, 5, 6 years later and their disease returns, and you biopsy it, you prove it's still indolent lymphoma, let's say follicular lymphoma in this case, then I think you're having a conversation with that patient about options. And the most common conversations right now are to offer lenalidomide and rituximab, which received FDA approval based on the Augment study. And lenalidomide rituximab performed far better. The median progression-free survival was like 28 months, very durable. And there was actually an overall survival advantage for patients with follicular lymphoma in that study.